Hi everyone, we are back again on the same familiar topic, heart attack. Today I'll be talking more on the intervention when anyone is having heart attack. The pump needs urgent attention and time is of the essence. Acute treatment will involve checking the airway, looking for any foreign body, mucus, bleeding from all the orifices, the mouth, the nostrils, the ear, sunshine, as the case might be. Check the breathing. Put your stethoscope everywhere. What is the respiratory rate, any deformity of the chest region, and of course, circulation. Get vital signs from those good human beings called the nurses. The vital signs, the BP, the respiratory rate, heart rate, and temperature. And I think in future, maybe they will incorporate pain to vital signs. I don't know yet. Cardiac monitoring, hook it up. What's the symmetry? We need to know O2 sat here. Greet this patient with aspirin, 325 milligram, non-enteric coated. Tell the patient to chew. But before, ask, do you have allergy to aspirin? And are you bleeding anywhere? And are you asthmatic? No, it's just here and there. Just find out, be safe. Give IV fluid, set IV fluid line. Depends on the situation. If it is inferior wall myocardial infarction, you might need to be prepared to really give fluid. And depends on what the vital signs is saying. If there's hypotension here, then you need to give normal saline. But for maintenance, 0.45% saline and D5 water at 100 cc per hour is enough. Order your EKG, and not once. When you order EKG, you repeat. If oxygen saturation level is less than 92%, give about 4 liters per minute per another prong of oxygen. Nitroglycerin, be careful. What is the blood pressure here? If it's anything less than 90 over 60 millimeters of mercury, be careful. 2. Is this inferior wall myocardial infarction? Be careful. 3. As these patients, my uncle, male patient in particular, taken phosphodiesterase inhibitor recently, Levitra, Cialis, Viagra, find out. If they have, don't give it. Don't give nitroglycerin. Morphine for pain, but watch out for the BP also. Get vital signs before administration. Okay, first thing first. When we've taken the first steps like that, then the next thing is what is happening at cath lab. Find out if they are there and they are ready within 90 minutes at the emergency room and 12 hours of symptoms, let percutaneous intervention be done. We are still treating my uncle. Laboratory investigations will be done at this time. Cardiac enzymes, troponins every 8 hours, about 3 times done, and CKMB. We're going to check glucose because if this uncle should have hypoglycemia, he might actually die not from heart attack, it's they have hypoglycemia. Complete blood count is anemia here, and I'm going to check for what is wrong with the liver and the bleeding or coagulation cascade. INR, APTT. How about the kidney? Is the kidney working well? Blood urea, nitrogen, and creatinine, electrolytes, potassium, calcium. Because later on we'll be talking about giving the Josein, magnesium as significantly important or unimportant we think. If it is low, can give us what we call torsade point from long QT syndrome to ventricular tachycardia and ventricular fibrillation, and that might be the cause of death. Lipids. Let's find out if we have low density lipoprotein or high density lipoprotein in appropriate proportions. Let's find out. Let's do those tests. We are still not done. Still treating my uncle. Now radiological investigations. Let's have the EKG repeated again. What about the chest X-ray? Is the result of EKG out? Okay, it's out. What have we found out? Yeah, it is ST elevated myocardial infarction. No, it is non-ST elevated myocardial infarction. Okay, why no ST elevation anywhere? But there's depression. Okay, no bundle branch block, no pathological Q wave. All right, then no thrombolytic agents here. Yeah, if it is non-ST elevated myocardial infarction or unstable angina, no thrombolytic agents. What am I going to do then? Okay, do what you call TIM and give low molecular weight heparin and angiography if TIMI score is greater than 3. And what is TIMI score all about? Thrombolysis in myocardial infarction. What are we looking for? Is this patient greater than 65 years old? That's one. Are there 3 factors or more for coronary artery disease? Is there any coronary artery stenosis greater than 50% here? Has this patient used aspirin in the last 7 days? Any problem, ST deviation greater than 0.5 millimeters? What about the cardiac enzymes? Are they raised? And is it less than 24 hours that this patient is presenting? So when we put all these costs together, if it's greater than 3, then we have to give low molecular weight heparin and angiography. We're not done yet. The EKG is here, and it is ST elevated myocardial infarction. Oh, bad. New bundle branch block could be seen, and pathological Q wave are present. I'm going to ask for CAD lab right now for percutaneous coronary angioplasty or percutaneous coronary intervention, depending on what you call it, is the same. If the answer comes back from my wonderful nurses and they say, oh, doc, that's not reachable right now, the doctor is not around, or my center doesn't even have it at all, wow, then I have to rule out contraindications to thrombolytics. And what are they? To start asking history from this uncle that is under attack. Thank God we've given him aspirin. So start asking, have you had intracranial hemorrhage? And the last 3 months, have you had ischemic stroke? Do you have brain tumor? Any head injury? Have you been diagnosed with aortic dissection? Did you have arterial puncture recently? Have you undergone any major surgery within the last 3 weeks? any anticoagulants that you are taking right now, like warfarin or Xarelto. And if all those things are favorable, I mean, if they are all absent and we could give thrombolytic agents, I would prefer recombinant tissue plasminogen activator, but with due consultation with a cardiologist, if you're not one. So other agents could be used as thrombolytic agents, like TNK and streptokinase. But there's a problem with streptokinase is getting out of favor because when you administer it once, it's likely that the patient will develop antibodies against it. And when you administer it a second time, it's not going to do anything to help the patient. So streptokinase is getting out of favor. RTPA is the one that most people will use, but we have to rule out thrombolytic contraindications first before administration. Okay, it is ST elevated myocardial infarction on the EKG. Yeah, we need to consider the road we are going to take before we embark on the trip. Okay, check. Which leads are affected? Leads 2, leads 3, and AVF. Oh, that is inferior wall. It has a better outcome or better prognosis. Right ventricle is infarcted here. There will be hypotension and bradycardia commonly in them, and is likely supplied by right coronary artery in majority of people. Be careful here if it is inferior wall. Be careful with what to do with the beta blockers, nitroglycerin and morphine, because they are prone to bradycardia and hypotension, like I've earlier said. Okay, the EKG is out, and it is STEMI, which leads 1 to 6, namely 1 and AVL. Oh, anterolateral wall. Oh, but this has the worst outcome because larger area is infected and can rupture. It is supplied by left anterior descending artery and left middle circumflex. No, it is at V1 to V2 that is deceptive. We are not done, but almost done with acute treatment for my uncle. Okay, I'm going to give anticoagulants in form of low molecular weight heparin. Anticoagulant means clot busters. Low molecular weight heparin, 1 milligram per kilogram subcute, but I need to check something before then. Check my INR and APTT. We give antiplatelets. Ticagrelor is raining right now, and it will work better if it's given with aspirin. I'll give my beta blockers, like metoprolol beta 1 selective, but there's possibility of contraindications to beta blockers, like if my uncle is too old and is having what we call sick sinus syndrome, or there's massive hypertension, or there's bradycardia, or there's heart block somewhere. I'm not going to give it. Or it's massive or severe asthmatic attack. Then I can use something else. I'll take a medication from a group called non-dihydropyridine calcium channel blockers, and I will use diltiazem here. I'll give my statin, CGMD coa reductase inhibitors, pass the Foley catheter to monitor fluid in and out. Of course, send consults to cardiologists. Don't do it alone. Let's team up to save my uncle. We have the contd family. If not, your good work will become evil spoken of. Take history. Because for thrombolytic agent administration, so many things, consent must be signed. Take your proper history, do physical examination, and plan for post-myocardial infarction management. Because it's not going to be done immediately the patient says, I'm fine. More will have to happen as per treatment after all. Okay, thank you very much for watching my video. We still have more to talk on this familiar topic called heart attack. See you soon. Thank you.